Thank you, Sri Priya. Thank you all the participants for joining for today's session. So we have a continuation of pain management. We have heard about the step 1 and 2 ladder last week from Dr. Mehdi. Today we'll be talking about the step 3. I remember you had a few questions on the morphine dose and many other things last week. So today we'll be talking in detail about it. Today we have Dr. Sunil as our faculty. Dr. Sunil is the additional director of TIPS, which is the academic and clinical part of Pallium. He has done his master's in palliative medicine from Cardiff University. He has been with Pallium India for 15 plus years in this position, and he's overseeing the clinical services as well as the academic wing of Pallium India. Welcome, sir, for today's session. Over to you.
Thank you, Sri Priya and Sri Devi. Good afternoon, everybody. So you have completed the first session on pain management, and you have covered non-opioids and opioids for mild to moderate pain. So today we will be dealing with opioids for moderate to severe pain. So let me share my presentation. Okay, so today we are planning to cover the strong opioids and its mechanism of action. And most of the problems occurs while we use opioids in our practice. So I plan to give this learning as patient stories, so that I think most of the practical aspects will be covered, and what are the adverse effects of opiates and how to manage them. And it's also important to understand the prices of different opioids, because this is one of the vital thing which will help the patient to get symptom control. If you prescribe a patient with a costly medication, sometimes the patient may not take, and that person may continue to come to you and will tell you that there is no proper symptom control. So poor adherence to the treatment is one of the most common reasons um, for incomplete symptom control. So all of you know this is the WHO analgesic ladder, and in the second step we have opioids for mild to moderate pain, which you have already completed, and the available opioids in the second step of WHO analgesic ladder in India are tramadol, tapentadol, codeine, and dextropropoxyphene. So we are going to deal with the third step of analgesic ladder. Okay, so I would I would like to ask you, if you see a patient like this, what would be your most important concern? Suppose you are seeing this patient. What is your important concern? Can anybody tell me?
I think the way he is sitting,
Hmm.
he has either got a mandibular pathology, which is causing pain, or pathology in the oral cavity, say for example a tongue lesion or tongue malignancy, some ulcer in the tongue, which is causing this kind of discomfort for him.
Yeah.
So obviously it's more likely to be a radiating type of pain related to these two areas of pathology.
Yeah, thank you, Dr. Muhammad Sajid. So you are right. So this patient, when you see a patient like this, I think his facial expression should attract us towards him. And we should also understand that he is suffering from severe pain. So if you see such a patient, how do you manage this patient in your practice? So before that, I would give you the history of this patient. This is a 56-year-old man with carcinoma of the larynx, and he has undergone his treatment with the tracheostomy and radiotherapy. But then he presented with severe pain, which he describes as sharp pain, 10 by 10, and the pain scale, and without any radiation. He was also unable to sleep for the last 2 weeks due to pain. So, how are you going to manage this patient? Anybody? I can see that there are some responses coming. Okay, Dr. Manoj says,
Sir, should I read it out?
yeah.
Dr. Amrita says, can we move to step 3? Dr. Haripriya is telling NSAIDs and anxiolytics
Mm,
and start opioids,
mm,
adjuvants and counseling, antidepressants at night with anxiolytic at night. Dr. Vandana is telling start opioids.
yeah. So I would like to ask, why should we start opioids in this patient? What is the indication for starting opioid in this patient?
So there is another response from Dr. Jaya, opioids with airway management like tracheostomy. And then a strong one like morphine to overcome severe pain. So the reason for starting opioids is severe pain 10 out of 10.
Okay. In the pain management, in the basics of pain management, we told that the management of pain is mainly with the WHO analgesic ladder. So the first step of WHO analgesic ladder is to treat mild pain. And you can take 0 to 2 in the pain scale as mild pain. And second step of WHO analgesic ladder is to treat moderate pain. You can consider 3 to 6 for moderate pain, and 7 and beyond should be considered as severe pain. So this patient is suffering from severe pain. So what should be the or what are the medications that is coming in the third step of analgesic ladder? We know that it is opioids for moderate to severe pain. So you should start an opioid for moderate to severe pain, plus or minus non-opioid, plus or minus adjunct. So these are the medications that we need to use in the third step of analgesic ladder. So as this patient is suffering from 10 by 10 pain, that is severe pain, we have to use opioid for moderate to severe pain. So which one would you use in this situation?
Sir, there are responses for morphine, and can we go down? Okay, that's I think Dr. Haripriya that will come again in today's session. And there is one response: parenteral analgesics first for acute relief.
Yeah.
Dr. Vandana has raised her hands also.
Yes, Dr. Vandana.
Yes, sir. Sir, good afternoon, sir. Sir, in case of severe pain, I think it is better to start with parenteral opioid to overcome the severe pain, and then after that switch on to oral opioids once the pain score is under to the patient is more comfortable. But this again depends on where the patient is, whether he is in the hospital or whether he is at home. So at home, we do not have the option of parenteral, then we might have to automatically go for oral opioids.
Yeah, thank you, Dr. Vandana. That was brilliant answer. So this patient is suffering from 10 by 10, and we should try to manage the pain as early as possible. We should provide pain relief as early as possible. So it is important to use parenteral opioids if possible. So the most commonly used parenteral opioid is injectable morphine. And uh, you can see uh, this patient, look at his facial expression, and after an hour, his facial expression, he's smiling at us. So this was made possible by injectable morphine. How do you give injectable morphine for this patient? What would be the dose, and how do you titrate? Anybody can unmute and speak. Yes, Dr. Vandana, please unmute and speak.
Yes, sir. Sir, as we all know, morphine is available in the ampule form in 10 mg. So that is, we can take 1 ml that contains 10 mg, dilute it to 10 cc, and then we can give titrated doses in incremental doses. Start with 2 ml, 3 ml, see the comfort of the patient, wait for it to act, and then depending on that, we can take care of the pain. This also helps when we give titrated and diluted form. We know that it's not going to cause the commonly encountered and side effects like respiratory depression or drowsiness.
Yeah, thank you. The strength of ambule, it varies from state to state. We get 15 milligram ampules, but I know there are some states where 10 milligram ampules are available. So it would be different. I'm going to this intravenous titration. It is known as intravenous morphine titration or intravenous morphine trial. So how do you give intravenous morphine? So as we have 15 milligram ampules, so we dilute 1 ml of morphine with 9 ml of normal saline. So total 10 ml of the solution, and each 1 ml of this contains 1.5 milligram of morphine. So we give injection morphine 1.5 milligram at 10 minutes interval. But what is the immediate side effect you are expecting by administering injection morphine to a person?
So breathing difficulty?
Okay, Dr. Madangi Santosh Kumar, breathing difficulty. That's not very correct, but it can occur very, very rarely. But what is the most common immediate side effect?
Drop in blood pressure?
Itching.
Yeah, these all are side effects, but that is not the most common side effect that you are going to see immediately.
Sir, there are responses: nausea, vomiting, respiratory depression, and itching.
Yeah, we will come to the side effect at the last of the session, but nausea and vomiting, that would be the immediate side effect that you are going to see. So in order to prevent the nausea and vomiting that may occur in some people, about 33% of the patients, you need to give an antiemetic, and we give injection metoclopramide 10 milligram IV, and then start with injection morphine titration. Okay, what would be the end point, or when would you stop giving injection morphine? Can anybody tell me?
So the patient looks sleepy. He starts sleeping comfortably. As we give the dose, the pain comes down, and as he overcomes the pain, you can immediately make out that he starts feeling sleepy because he has not. That is generally what we see when we start giving morphine.
Yeah, Dr. Vandana is partly right, but this is the end point. Either the patient has satisfactory pain relief. So some patients, they have satisfactory pain relief without drowsiness, or the drowsiness, whichever be the first. That's the end point. So all the patients will not get good pain relief with injectable morphine, and they may develop drowsiness instead of pain relief. So we have to stop the morphine at that moment, and we have to add adjoint medication. But if the patient has satisfactory pain relief without drowsiness, so then that's the end point of injection morphine titration. So when you do injection morphine titration, we can have a chart like this, so that it will be easy for you to monitor. And you can have time, pulse rate, respiratory rate, blood pressure. What is the pain score? Is the patient drowsy or not? And what is the dose of injection morphine you have given? And in this patient, suppose we have started morphine titration at 10 a.m. and at that time pain score is 10, and patient is not drowsy, then you will give injection morphine 1.5. You will wait for 10 minutes. At 10 a.m., you will ask the patient, what is your pain score now? Patient says it is 7. So you will record pulse rate, respiratory rate, blood pressure again, and you will look at the patient and will ask the patient, are you drowsy? No. Then you will give another 1.5. So this is repeated. Either the patient has satisfactory pain relief or the patient becomes sleepy. So you can see at 10:30 a.m. in this patient, the pain score has come down to 1. That means patient has satisfactory pain relief and the patient is not drowsy. So then you will stop injection morphine. So this is the end point in this patient. So this patient has consumed 4.5 milligram of injectable morphine and has good pain relief. So is this a outpatient procedure or inpatient procedure?
Sir, inpatient procedure is the responses that we are
Inpatient.
getting.
Inpatient.
Both. It can be done in both.
Yeah, for intravenous morphine titration alone, you need not admit the patient. You can do it as an outpatient procedure, and we do 1 or 2 intravenous morphine titration, injectable intravenous morphine titration every day in the outpatient department. So we have given 4.5 milligram of IV morphine with good pain relief for this patient, and you want to send the patient home, so that we need to give oral morphine. So how are you going to convert this injectable morphine to oral morphine? What would be the dose that you would start in this patient? Anybody?
So there are a few charts. 4.5 into 3. Or less thrice there we dose 5 milligram only at night initially.
Is it
Okay.
equivalent dose, sir? I'm not sure.
Sorry, Dr. Vandana?
Sir, is it equivalent dose? Not
Yeah.
sure.
So there are various methods that is adopted for intravenous morphine titration, but the one which I have advised is the one which was experimented and published in Institute of Palliative Medicine by Dr. Rajagopal and his colleagues. So according to their findings, whatever be the dose you have given intravenously, and if that has given good pain relief, you can directly convert the same amount to the oral morphine. So 4.5 milligram of IV morphine means you can give 5 milligram of oral morphine, because 4.5 milligram of oral tablet is not available. So the next possible dose is 5 milligram. So you can start with 5 milligram of oral morphine. But how frequently we need to give oral morphine?
every 4th hourly?
Yeah. So we have to give more tablet morphine every 4 hours. So you can start. Suppose I have written when the patient wakes up, make it 6 a.m. Okay. Then at 10 a.m., then 2 p.m., 6 p.m., and 10 p.m. So that it is every 4 hourly. But at 10 p.m., you can see that we are giving double dose instead of the normal regular dose. So in this patient, you are giving morphine 5 times daily. Uh, and so you know that the duration of action of morphine is 4 hours, but we are giving double dose at night in order to avoid waking up at 2 a.m. And we are also adding half as and when needed dose. So this is how morphine need to be prescribed. And for those injection morphine is not available, we can also give oral morphine trial. So if the patient is opioid naive, that is the patient has not taken any opioids, then you can start the patient on 5 milligram of morphine for hourly and SOS. Whereas if the patient is already on weak opioids, you can start with 10 milligram of oral morphine for hourly and SOS. So this patient, we have started him on 5 milligram of morphine for hourly and SOS. And he was comfortable with 5 milligram morphine for 2 weeks. But then he started taking 4 SOS doses of morphine per day for the last 4 days. And he is coming for review with you. What would you do now? And the next question is, how frequently would you give SOS dose of oral morphine? So let's answer the first question.
Sir, we need to tell him about the adverse effects and the possibility of dependence when he comes, if he takes frequently, one thing. And we also need to start some other adjuncts because he is getting frequently breakthrough pain. So maybe we can give another drug so as to decrease the chances of dependency and the total dose of opioids.
Okay. Anybody else want to comment on this?
Can change the drug, this one response.
Why is patient taking 4 SOS dose? It is because of pain, isn't it? The patient is taking 4 SOS dose because he gets pain in between. And you have written SOS dose and have advised the patient that you can take SOS dose. And that's why patient is taking 4 SOS dose. But as Dr. Vandana told, we have to be careful because there is a rare possibility of dependence. So this patient is a patient who has an advanced malignancy. But that should not withhold us from giving SOS dose of any opioid. So as this patient is taking 4 SOS dose, that's an indication to increase the dose of morphine if there are no toxicities of morphine in this patient. So what you have to do, if the patient is taking 2 or more than 2, PRN means it's same as SOS dose. Okay. So if the patient is taking 2 or more than 2 SOS doses, then you have to increase the dosage of morphine by 30 to 50% every 24 to 36 hours. Okay. You can increase the dose of morphine every 24 to 36 hours. So increase it by 30 to 50%. So this patient is taking 5 milligram of morphine. If you increase it to 50%, then that will be 7.5 milligram. 30%, it would not be possible to give, because 30% of 5 milligram would be 1.5. So total 6.5 milligram of morphine, that would not be possible. So nearest possible dose would be 7.5 milligram. And the 10 milligram tablet, some patients will complain that it is not easy to break it into 4 pieces. So even 10 milligram would be okay in this patient. So that's why I have written from 5 milligram, you can increase it to 7.5 to 10 milligram. So what is the indication of increasing the dose of morphine? If the patient is taking 2 or more than 2 SOS doses. And how frequently would you give SOS dose of oral morphine? And why?
Dr. Amrita says as required.
Yeah, I mean, what should be the time interval between the 2 doses?
So we would give at least an 1 hour duration for 1 dose to work. If the patient still has pain after an hour, we can give an SOS dose.
Yeah, thank you, Sharon. And can you tell us why 1 hour?
That's the duration needed for the therapeutic levels to the therapeutic levels of the morphine to reach the blood.
Yeah, thank you. Exactly. This is the morphine or a poppy plant. Okay. And this is legally grown only in 3 states of India: UP, MP, and Rajasthan. I don't know whether there is anybody from these states in this group. And if so, they might have seen this. And you can see uh, this seed-like thing is known as pod, POD, pod. And the farmers will make small cuts on the pod, and you can see the sap is coming out, and they will collect it and dry it in sunlight, and will transport to government opium and alkaloid factories, from where they will make morphine powder. Okay, so this is legal only in 3 states. And once you when you give morphine orally, it is absorbed from the upper small intestine, and morphine is hydrophilic. That means it is water soluble. So it has a slow onset of action, but because of the same property, it has a longer duration of action, up to 4 hours. And morphine should not be given sublingually or buccal or gingival route, because from this route absorption is very, very low. And we don't know how long the patient need to keep this morphine under the tongue. So it is not advisable to give morphine sublingually. And if somebody says after sublingual administration, they have good pain relief, that means the patient has swallowed it. But the most important thing is it has a bitter taste. So whenever you powder the morphine, you have to sweeten it with some fruit juice or sugar. And what happens after you swallow the morphine? It will go into the gastrointestinal tract, and then it will be absorbed into the blood vessels of intestine, and from there it will goes into portal vein, and from portal vein to liver, where metabolism takes place. And then the metabolites are liberated into the systemic circulation, and this metabolites will give you the pain relief. So as I told you, metabolism mainly occurs in liver, but a part occurs in JAT as well as in kidney, and 90% are converted into metabolites. And most important metabolites are morphine 3 glucuronide and morphine 6 glucuronide, in short M3G and M6G. And out of this, only one component is only one component will give you pain relief. Which component is that? It is that. It is M6G. Okay. And it is formed only in smaller quantity compared to M3G. So M6G is the active component which will give you pain relief, and M3G doesn't have much action in our body. So now you know that after absorption, it has to go into the, after administration, it has to go into GI tract, and from the upper small bowel, it is absorbed, then goes into liver where metabolism takes place, and metabolites are liberated into systemic circulation, which will give you pain relief. So this process will take some time. The patient will start getting pain relief by about 30 minutes, but the peak of pain relief occurs by about 1 hour. So it is always safe to administer oral morphine tablet after 1 hour of the previous dose. So wait for 1 hour and then administer the next dose. So now we have increased our patient's morphine to 10 milligram 4 hourly because he had pain. But he says it is very difficult for me to take it every 4 hourly. Sometimes I don't remember. I forget it very easily. Do you have any other option? What would you tell this patient?
There is a comment, combination of drugs, sorry, 2.5 milligram, then sustained release form. I think combination of drugs is also related to the question you asked. It just came in the chat.
Okay. So this patient says, if you give me less frequently instead of 4 hourly, give it maybe twice a day, then I am okay to take it. But 5 times a day, it is too much. So
sustained release and slow release are the options people have.
Yeah. So we have sustained release morphine, which is known as SR morphine, or also known as controlled release morphine, but the same. So sustained release morphine has a duration of action of 12 hours, whereas we already told that the fast acting morphine or immediate release morphine, it has a duration of 4 hours. So if we can give SR morphine to this patient, he need to take it only twice daily. So what would be the dose for this patient? What would be the dose of SR morphine for this patient? What is the total dose of morphine he is getting? Ten milligram per hourly means how much? Total dose?
50 milligrams,
60 mg.
Yeah, it is 60 mg. So if you convert it into SR morphine, how would you give that dose?
30 mg to twice a day.
Yeah. So it should be 30 mg PD. Is this enough? Do we need to give any other medication with this? This patient.
For nausea and vomiting.
Yeah.
Tablets.
Yeah, that we can give. But for this
For
patient.
breakthrough pain.
Yeah. This
Immediate
patient,
release morphine for breakthrough pain.
What should be the dose of immediate release morphine?
10 mg as well.
Yeah, this patient was taking 10 milligram 4 hourly. So the breakthrough dose is same, 10 milligram SOS. So sustained release morphine 30 milligram BD with the usual immediate release or fast acting morphine 10 milligram SOS dose for as and when needed pain. So these are the preparations of morphine available to us. Acute solutions, that is syrup, then tablets in 2 forms, immediate release as well as controlled release. These are also available as capsules and injections. So we started this patient on 10 milligram of morphine 4 hourly, and he was comfortable, but uh, he was brought to the casualty with the drowsiness, excessive drowsiness. And when you saw this patient, he is not responding. And then you thought that you will investigate. And then the only positive finding or the abnormal finding was he has a serum creatinine of 5 milligrams per deciliter. Would you do anything with morphine dosage in this patient?
Sorry, there are two questions from the last scenario. How long to wait before giving immediate release morphine?
Yeah, maybe sustained release morphine, if you administer it for the first time, it may take some time, maybe up to 2 hours. But once it has taken over by maybe after 3 days, then I think it may be given at any time if the patient has pain. But in between, you have to the duration between two immediate release morphine should be 1 hour. What are the other questions, Sridevi?
The last question, I think it was about how long to wait before giving immediate release. How long to wait before giving immediate release morphine for breakthrough pain?
Yeah, I think that's what we have answered now.
Yes, sir. There is no other questions, sir, only that part.
Okay. So in this patient, what are you going to do? Or do you need to do anything with morphine dosage in this patient?
So we can reduce the dose or increase the interval as metabolites excretion will be affected, and dose adjustment is what Dr. Kanika has said.
Yeah, that's right. So we have to understand how morphine is excreted from the body. It is mainly by glomerular filtration. So what happens in renal failure? This patient has renal failure because of serum creatinine. His serum creatinine is 5. So the morphine and its metabolites M6D gets accumulated. So that whatever you are giving, it's there in the system. It is not going out of the body. So if you continue to administer with regular dose and regular interval, then there will be more of drowsiness, and then it may go to other complications. So in this patient, we have to reduce the dose, as well as instead of 4 hourly, you can make it TID or BD or OD according to the serum creatinine. Or you have to use other opioids which are renally safe. So fentanyl, methadone are the two opioids which are better in case of patients with renal failure. So because of his renal failure, we reduce the dose. Okay. So we reduce the dose to 5 milligram 8 hourly, and he has good pain relief. But after 2 months, because the patient is disease advanced, he is nearing end of life, and he is unable to take anything orally, and he is at home. And if he is not taking morphine, he has very severe pain. So what would you do in this patient? He is unable to take anything orally.
A patch, sir. Can we
What
use patch? Buprenorphine patch, fentanyl patch, or
yeah. Thank you, Dr. Vandana. Any other comments?
We can also use subcutaneous form of opioids.
Yeah, subcutaneous opioids. Good answer. Anybody
Tramadol
else?
patch is another option.
Tramadol patch.
Yes.
Okay. I have not seen tramadol patch till now, but I don't know whether it is available somewhere.
Ian is telling in UK syringe drivers are normal practice, and it depends on what is available. Patches.
Yes. So consider the Indian situation. What would you do?
Patient controlled injectables.
Yeah. Is it possible at home? And would your hospital allow the patient to take injection morphine home? That's also another question. Um, so, uh, so let's look at the routes of administration of morphine. What are the routes through which you can administer morphine? You can give it intravenously or subcutaneously, orally, and you can give morphine parectally, epidural, and intrathecal. So, if the patient is at home, which route would you select out of this?
One response is PR.
Yeah, parectal morphine.
Yeah, many of them are responding as PR.
Yeah, we can use morphine parectally. And suppository, morphine suppository is not available in India. Okay. So if you administer morphine parectally, you can use the same dose of morphine, that is 5 milligram. And if you are administering 8 hourly, you need to administer only 8 hourly through parectal route. Oral route and parectal route are comparable. Okay. So the pain relief would also be the same. So you can take 5 milligram of immediate release morphine and add 2 drops of water because it is hydrophilic, and make it a paste and rub it over the rectal mucosa. And now we are moving on to another patient. This is another patient, Mrs. K, who is a 55-year-old lady with carcinoma of the colon who has abdominal pain, which is continuous in nature, and she is on 10 milligram of morphine 4 hourly. And she has good pain relief with uh, uh, 10 milligram of morphine 4 hourly. So the patient asked, is there any other option to reduce the intake of medication? So the doctor advised them to replace it with a fentanyl patch of 25 microgram per hour. But next day, the patient comes to you and tell you that they have replaced the fentanyl patch after 5 hours as she had no pain relief. So what will you do for this patient? Anybody?
Check the patch has been correctly applied. It will take time to act, at least 8 hours or 12 hours for onset. Everyone is telling onset of action is 12 hours or late.
Yeah. So all of you know that, but this has happened to one of the patients who visited us. So she was asked to place a fentanyl patch. They placed a fentanyl patch, but without any other opioids to cover for the pain relief up to 8 to 12 hours. So she replaced the fentanyl patch and came to us. So it is very important to educate the patient regarding what all can they expect. So it is very important. So as you know that, but the patient don't know. So a few things which we have to understand about the phenyl patches. When you apply it, it will first form a subcutaneous tissue depot, and from this subcutaneous tissue depot, the phenyl will be liberated constantly into the systemic circulation. So for this subcutaneous tissue depot to occur, it will take about 8 to 12 hours. So once you apply the phenyl patch, it will take about 8 to 12 hours for pain relief. So till that time, you have to continue with the previous opioid which the patient was taking. Otherwise, the patient will suffer pain and they will do what this patient has done. And you know that its action is for 3 days, and the area of application should not be shaved, because if you shave the area, it will have multiple abrasions which can increase the absorption, as well as if the patient has fever, it is also going to increase the absorption. So as once you apply the patch, it will constantly liberate the specific amount into the systemic circulation. We will not be able to alter the concentration. So it is advisable. It should not be used in patients who has unstable pain. Only those patients who has good control of pain, then that opioid can be converted to fentanyl. Otherwise, if the patient has frequent increase in pain, and they need frequent SOS dose of opioid, then it is not advisable to use fentanyl patch. But I know that many people use fentanyl patch even in acute pains. That is not correct. And there are 3 types of preparations available: injections, transdermal fentanyl patch, and oral transmucosal fentanyl citrate, which is like a lollipop. You have to rub it over the oral mucosa, which will give you instantaneous pain relief. But OTFC is not available as of now in India. Compared to morphine, this is lipophilic, and it is 100 to 150 times more potent than morphine. So in case of opioids, we compare the potency with morphine. So a potency means it is the weight by weight ratio. So morphine, with 10 milligram of morphine, the patient got pain relief of this much. So for fentanyl, what should be the dose that need to be given? That is known as the potency, weight by weight ratio. So 60 milligram of oral morphine equivalent per day can be considered as 25 microgram per hour patch of fentanyl. So this is another patient. Mr. P, a 70-year-old man, has carcinoma of the lung, and he is complaining of throbbing pain on right front of chest, which is continuous in nature, and his scores 5/10. He is a non-epileptic and is on phenytoin, 100 milligram BD. How will you manage his pain? Anybody?
Moderate pain, so step 2.
Which medication to be used? Step 2.
Dr. Vandana, you have an answer.
Sir, because it is moderate pain, we should go with step 2. Already patient is on phenytoin, so adjuvant is there, anticonvulsant is there. Maybe we can use oral morphine for this patient, sir.
Okay. So yeah.
Or a fentanyl or a patch also, because it is a continuous type with not much waxing and waning. So a patch also could be appropriate.
Okay.
There are a few more responses on weak opioids like tramadol.
Okay. So Dr. Vandana, what about tramadol? I am asking you because you are answering.
So, yes, sir, because sir, tramadol is known to be epileptogenic. So probably we might better avoid it.
Yeah, that's right. So in this patient, even though the patient has moderate pain, if you look at the WHO analysis ladder, we have to use the step 2 opioids. But in the step 2, we have tramadol, tapentadol, codeine, and dextropropoxine. Out of this, tramadol and tapentadol both can reduce the seizure threshold. So this patient is already has epilepsy, and tramadol can reduce the seizure threshold and it can precipitate the epilepsy or the seizure activity. So it is wise not to use tramadol or tapentadol in this patient, and instead we can use a low dose of morphine. But I would not use the fentanyl patch because we don't know how much would be the opioid need in this patient. So we have to find out the opioid use, and then only I will convert it to fentanyl patch if the patient has a stable pain. So this is another patient, Mrs. P, on tab morphine 50 milligram 4 hourly. She attends your clinic with severe pain. You have injection pentazocine and oral morphine tablet. How will you manage? Injection pentazocine is Fortwin. Okay. So how will you manage this patient?
Sir, injection pentazocine can be given for acute pain relief. And then after that, she can be asked to continue with morphine.
Okay, thank you, Dr. Vandana. Any other response?
There is a response from Dr. Haripriya.
Uh-huh.
Pentazocine first and oral morphine on maintenance.
Yeah, that is what
For
Dr.
the last,
Vandana
yeah.
also told.
And again, pentazocine is agonist, antagonist.
Okay, so let's see. So for this, we need to understand a little bit of pharmacology of opioids. A drug to satisfy to be an opioid, it should have two properties. One is that it should produce its action by combining with opioid receptors. Its action is produced by combining with opioid receptors, which is mu, kappa, and delta. And its action should be antagonized by naloxone. So these are the two properties for for a drug to become to be an opioid. Okay. We can classify opioids into agonist, antagonist, and agonist based on the receptor interaction. So what is an agonist? What is an antagonist, and what is agonist? Agonist means when opioid attaches with the opioid receptor, it will produce the physiological action, that is pain relief and other side effects. That is agonist. Antagonist means the examples of agonist are most of the opioids we know are agonist. Morphine, fentanyl, methadone, tramadol, all those are opioids. What is an example of antagonist? It is naloxone and naltrexone. Suppose if I administer naloxone to any of you, what would be the action in your body?
No action if we give it without any previously added opioid.
Yeah, that's what you have to understand. Antagonists work only in presence of another agonist. So if you are not on any opioid, it is not going to have any action in your body. So antagonist competitively inhibits the agonist. That's what happens. And the agonist-antagonist means this opioid will have agonistic action on some receptors, whereas it will work as an antagonist on other receptors. So this is important from a clinical point of view to understand. Agonist and agonist examples are the commonly used two agonist and agonists. One is buprenorphine and the other one is pentazocine. And one of the main difference between agonist and agonist is this. Look at this graph. The first one is belongs to agonist. On the x-axis, it's the dose of opioid you need, and on the y-axis, it is the pain score. Okay. Suppose you give morphine, which is an agonist, 5 milligram. Up till now, that will give some pain relief till this. And when you increase the dose to 10 milligram, it will give this much pain relief. And to 15 milligram, it will give more pain relief. And when you increase the dose, theoretically, it should give 100% pain relief if the pain is opioid, completely opioid responsive. So that means as the dose is increased, the pain relief will also increase. But look at agonist and agonist, like pentazocine. What happens? You can see till this point, when you increase the dose of pentazocine, you will get corresponding pain relief. But after this point, even if you increase the dose of agonist and agonist, it is not going to give you further pain relief. The curve is plateaued. So this is the main difference. This is known as ceiling effect for analgesia. Agonist and agonist opioids have ceiling effect for analgesia, whereas agonist theoretically doesn't have ceiling effect for analgesia. This is one important concept. But look at pentazocine. It acts as an agonist and agonist. It acts as an agonist at kappa receptor, whereas it has a weak antagonistic effect at mu receptor. So this patient is already on morphine, isn't it? So morphine is a mu agonist. So for this patient who is on morphine, you are administering injection pentazocine. What can happen? The pentazocine will compete with morphine, and it will displace morphine from mu receptors. Okay. And now the pain relief would be due to the action on kappa receptors. And another point that you have to understand is those opioids which are act on mu receptors are the potent opioids. So in this patient, what will happen? It can actually increase the pain rather than decrease the pain. So this is what can happen if the patient is on fairly large dose of opioid agonist. This patient is getting fairly big dose, 50 milligram 4 hourly, that is 300 milligram per day. So probably this patient can have more pain if you administer pentazocine. So it is not advisable to give pentazocine in this patient. So I think it is important to take a detailed history from this patient, and probably this patient might have missed a dose, or you can give SOS dose. Okay. So we will move on to adverse effects now. What are the adverse effects? It can be divided into two: side effects and toxic effects. So what are side effects? Side effects means these are adverse effects with the normal therapeutic doses. Side effects are adverse effects with normal therapeutic doses. So what are the side effects? Anybody?
Nausea, vomiting, itching.
Which is the most common side effect?
Constipation.
Yeah. So whenever you talk about side effects, first tell what is the most common side effect. So it is constipation, followed by nausea, vomiting, sleepiness, and tiredness. This is the common side effect. And there are other rare side effects. So itching, dry mouth, urinary hesitancy. These are the rare side effects. Okay. And about constipation, it occurs in almost 95% of patients. So that means almost every patient will have constipation if you start on opioids. So it is important to prevent this constipation by prescribing a stimulant laxative. Okay. So stimulant laxative is the drug of choice for opioid-induced constipation. Sridevi, Sridevi, you are on not muted. So 95% of patients will have constipation, and there will be constipation as long as the patient is on opioid. So you have to continue the laxative. Okay, don't stop the laxative. And as I told you, one of the example of stimulant laxative is bisacodyl. Another one is sodium bicosulfate and senna. And nausea and vomiting, it occurs in about 33% of patients. But the importance is that it is self-limiting. So after 3 to 5 days, the nausea and vomiting will disappear. So for the first few days, 3 to 5 days, you can give an antiemetic, which will act on chemoreceptor trigger zone. Okay. And these are the common drugs which will have good action on chemoreceptor trigger zone. Haloperidol, metoclopramide, domperidone, and we usually use metoclopramide. Sleepiness and tiredness, this is also self-limiting. This can also occur in about 33% of patients, but after 3 to 5 days, the patient will get over this. Now we'll move on to toxic effects. What are toxic effects? These are the adverse effects when the administered dose is higher than the required for pain relief. Okay, so when you administer higher than the required for pain relief, the patients will experience some adverse effects which are known as toxic effects. These are delirium, myoclonus, drowsiness, pinpoint pupil. Okay. So if the patient has toxic effects, that means you have to reduce the dose of the opioid. At first, somebody was talking about respiratory depression. So how common is this respiratory depression when we treat patients in pain with analgesics, especially oral morphine? How common it is? So this is a systematic review from 2003. And you can see it has written that most of these patients take medications by mouth, and there will be gradual increase in the dose of oral opioids, which ensures that respiratory depression is unusual. And it continues to say that when respiratory compromise does occur, an alternative explanation should be sought, such as pneumonia, pulmonary embolism, cardiomyopathy, or co-administration with another medication like benzodiazepines. So respiratory depression is very, very unusual. I have not seen even a patient with respiratory depression for the last 18 years of my experience with opioids. So what about this opioids causing addiction? So this is also low, but we have to be careful. That's the most important thing, especially in patients with non-cancer pain. There is a distinction between people call addiction as dependence. There are two types of dependence. One is physical dependence and the other one is psychological dependence. Psychological dependence is addiction. Okay. So for understanding this, I will give you a simple example. Suppose many of you might be taking coffee in the morning, and in one day, fine morning, you are not getting coffee. What would be your response? What is the reaction? What would be the reaction of your body? Would there be any response? No? Headache? Yawning? Irritation? Is it addiction? What's your opinion? Is it addiction? You were taking coffee for the last 30 years. Is it addiction? No? You are giving caffeine for the last 30 years to your body. And one day you are suddenly depriving your body of caffeine. And your body will react to that. That is physical dependence. But if you break into the neighbor's house where coffee powder and sugar has kept, then that is a psychological dependence. So that's the difference between physical dependence and psychological dependence. Okay. And American Academy of Pain Medicine and American Pain Society and Addiction Medicine gives this definition for addiction. You can see they define it as a genetic disease. Okay, it is a genetic, it is a primary chronic neurobiologic disease. It's a disease in genetically predisposed individuals where psychosocial and environmental factors can influence its development and manifestation. So that means if you have a gene for psychological dependence, and if you are working in a favorable environment like operation theater where all the opioids are available, and if you have a friend who misuse the opioids, then the environment, all the environment is favorable, and you have a gene, then there is a chance that you can have psychological dependence. And this is usually manifested by impaired control over drug use, compulsive use, and the patient will continue to use the opioid even though they understand it can produce harm to their body, and they will try to get it by any means. You will break into the next house, you will kill somebody, will do anything to get that. So that is craving. I'm not going into the details. So this is another prescription. Mr. X has very severe pain and you are starting him on morphine. You need to write a prescription. His serum creatinine is normal. What would be your prescription? Can anybody tell us? What would be the prescription? Okay, let me show you. There should be, when you prescribe opioids, there should be, there are some things that should be there in the prescription. There should be the name, age, and address of the patient. What is the dose of morphine you are prescribing, and for how many days, and how many morphine tablets are you dispensing, and the signature of the medical officer, his name, medical council registration number, and the address of the doctor. All these should be there when you prescribe opioids according to the NDPS Act. That is Narcotic Drugs and Psychotropic Substances Act, which is the governing act for all the opioids in India. So we should give metoclopramide for 3 days, 3 to 5 days. And we should continue bisacodyl. And you can call for review after 2 days, because we know that morphine its blood level gets stabilized by 24 to 36 hours. So this is another prescription. A patient is on tramadol 550 milligram 8 hourly for pain. Now she has severe pain and has started on morphine 5 milligram 4 hourly. Okay. And now the prescription is like this. The doctor has written tramadol 50 milligram Q 8 hourly, which she was taking previously. And then he added morphine 10 milligram half 4 hourly and SOS and syrup liquid therapy. Can any of you comment on this?
It's not, it's useless to give two a weak opioid and a strong opioid regular doses.
Yeah.
So it's we stick to just morphine, that would be enough.
Yeah.
Because she's not getting pain relief with tramadol.
Mm-hmm.
And probably add tab bisacodyl. If we're giving liquid paraffin regularly, then bisacodyl 5 mg HSOD.
Yeah, thank you, Sharon. As I told you previously, there should be name, age, gender, address, etc. Then this patient is already on weak opioid, that is tramadol 50 milligram 8 hourly. So you can directly start this patient on 10 milligram of morphine 4 hourly. And instead of liquid paraffin, because that is not the drug of choice for opioid-induced constipation, we should give a stimulant laxative, that is bisacodyl. Okay. And the last slide is this. This you have to understand, because most of our patients are very poor and we prescribe many medications which are very costly, like fentanyl patch or buprenorphine patch, and we don't understand how much costly it is for the patient. So just see, if you are giving a patient 5 milligram of morphine 4 hourly, that will cost only 3 rupees 50 paise. But to get the same pain relief, you need to the patient need to spend 24 to 50 rupees with tramadol. If you are using fentanyl patch, that will be 250 to 400 rupees per 3 days. For buprenorphine patch, it is 190, 1920 rupees. For methadone, it would be 4 rupees 50 paise. So the morphine is the cost or price of morphine is comparable with that of methadone. And this is one of the reasons for incomplete or poor symptom control. The patient will come and tell you, no, I don't have pain relief. We will start increasing the medication rather than looking into why the patient doesn't have proper pain relief. So I think I will end here and can take some questions.
Thank you, Sunil sir, for that elaborate session. We are open for questions, if any. Dr. Revati, can you be a little bit more specific? Like, was it a sudden comment or was it some kind of query? Check for complaints. So, sir, you want us to take up the case presentation for today, or sir, if you are saying something, you're muted.
Yeah, sorry. Whatever the participant wants, because if you have more doubts on this, we can continue to talk, or I think Dr. Kanika was supposed to present the patient story. Dr. Kanika, what do you want to do? Continue with questions, or do you want to present it now? You are muted, Kanika.
So we can continue with the questions.
Okay. If there are more questions, I am ready to answer if I know. So
Dr. Muhammad Sajid wants to know, can you review about addiction and its frequency? Dr. Sajid, would you like to throw some-
Yes, good evening, sir. Excellent talk. Plenty of points like the last class. Sir, you talked about addiction. You talked about physical dependence and psychological dependence. So if you just can give us a little bit more on this, because how should we deal with this problem of addiction? Is it just by counseling, or is it by say physical dependence and psychological dependence? How do you compare both?
yeah,
Really.
yeah. Thank you, Dr. Mahmood. When I told you that physical dependence, it is uh, it is it develops not only in patients who are taking opioids. It will develop in patients who are taking other medications also. We know that steroids, when you continue to give, it should not be stopped abruptly, because if you stop it abruptly, it can cause many problems, including hypertension, and patient may even die because of withdrawal reaction. So this is also applicable to morphine or other opioids. When you give opioids for at least maybe more than a month, then you have to taper it and then only stop. Otherwise, the patient will develop withdrawal reaction. But when withdrawal reaction is combined with craving, so when somebody is out of some medications, and if they have craving, that means they have psychological dependence. So that's the difference between physical dependence and psychological dependence. And the physical dependence can be manifested by many things like muscular pain, abdominal cramps, lacrimation, yawning, rhinorrhea, abdominal cramps, diarrhea. So these are the common symptoms with which patient presents when they have opioid withdrawal.
Thank you, sir.
Thank you, sir. Thank you, sir.
Dr. Jaya wants to know, is methadone available in India?
Yes, methadone is available in India since 2017 last, and it is available. It was available as syrup as well as tablet, but now it is available only as syrup in India.
We have Dr. Ian joining us from UK. So
Yes.
his question is, what is the ratio between oral morphine and oral methadone used for pain relief in Indian setting?
Yeah. So thank you, Dr. Ian. There is a paper which is published in Journal of Pain and Symptom Management, I think, in 2019. That is hospice and palliative care physicians' consensus on conversion between methadone and other opioids. And as per that, we follow that method, which is very easy. So according to that method, if the patient is using less than 60 milligram of oral morphine, or if the patient is opioid naive, then you can start that patient on 2 to 7.5 milligram of oral methadone per day. And if the patient is taking oral morphine equivalent between 60 to 199 milligram, oral morphine equivalent of 60 to 199 milligram, and if the patient is less than 65 years, then the conversion ratio is 10:1. That is 10 milligram of morphine is equivalent to 1 milligram of methadone. And if the patient is taking more than 200 milligram of oral morphine equivalent, or if the patient is more than 65 years old, then the conversion ratio is 20:1. This is what we follow.
We believe that your query has been answered, Dr. Ian. Moving on, we have query from Dr. Kanika. If a patient is a known case of opioid abuser or alcoholic dependence, can we still prescribe him with opioids for pain?
If a patient is known case of opioid abuser or alcoholic dependence, can we still prescribe him with opioids for pain? Okay, so we can prescribe, but we should frequently, there should be a contract between the patient and the physician. We will prescribe a particular dose, and they should not increase the dose without our consent. And and every time when they come to you, you should check the number of the medicines that is with the patient, so that you can understand how he is consuming the morphine. But there is another problem. This patient can go to another recognized medical institution and can also get opioid in India. But I know that in USA and UK that is not possible, because the doctor need to send online prescription to the pharmacy, then only it will be available. So the pharmacist will understand that this patient is getting opioid from many other institution, but it is not possible in India. So it is difficult for us, but still it is our the primary duty of a doctor is to reduce the suffering. So if the patient is in suffering, we have to use, or we have to give medication, but at the same time we have a duty to see whether the patient is misusing that medication.
Thank you, sir. Moving on, Dr. Revati Sharavanan's queries. Genetic mutation of metabolizing enzymes can affect efficacy or toxicity. In that case, should we have that also in mind while prescribing?
Yes, very true, Dr. Revati, because the codeine and tramadol is metabolized by cytochrome P2D6, and which shows wide genetic variation. And some patients may not be metabolizing this at all, and they may not have pain relief. So in that case, instead of oral route, sometime if you give it intravenously or some other route, then the patient might have pain relief, or some other if you use some other opioid, it can also have give pain relief. So that is important. And if you look at morphine, some patients, when they take orally, they may not have good pain relief, but if you change the route of administration, that can give good pain relief. So that is probably due to, because they have more of M3, M6, M3G production because of genetic variation.
Thank you, sir. Dr. Revati, we believe that your query has been answered. Dr. Jaya wants to know the dose interval of methadone.
Yeah, methadone's duration of action is 8 to 12 hours. So we can administer either BD or 3 times a day.
So we have covered the queries and inputs in the chat box. So now if anyone else would like to unmute themselves and discuss, we have a couple of more minutes left.
Yeah.
Excuse me, sir.
Yeah,
Sir,
I can see the
is there
question.
any difference in the management of opioid toxicity when we manage it intravenously, like when we give intravenous morphine, or and when we give orally? Is there any difference in the management, sir?
So when you administer morphine intravenously, the first sign would be the patient would be drowsy. So whenever you see the patient is drowsy, it is a warning that you should stop now. Otherwise, if you continue to give, then you will go into the complications like respiratory depression. But in case of oral morphine with usual doses, it may not be seen because it will take some time for the blood level to get it peak. The time of peak which will occur in case of oral route as well as intravenous route is different. In the oral route, it will occur slowly, but in case of intravenous route, it will occur suddenly. I think it is important to monitor the patient. That's the key. But if the patient develops respiratory depression, which I told you I have not seen, but if that occurs, if the patient respiratory rate is less than 7, or if the patient has cyanosis and patient is not responding, even though the respiratory rate is more than 8, these are the indications to give naloxone.
Thank you, sir.
Thank you, sir. We have, I think, we can take up the next question from Dr. Revati. Wants to know about drug interaction, drugs to be avoided with opioid.
I think usually there are no much interaction in case of opioids other than methadone, but methadone has a lot of interaction. I think we have a class on methadone, which would be the 20th session, I believe. In case of methadone, you have to be very careful because most of the medications which we use in palliative care has interaction with methadone. Either it can increase the methadone level or decrease the methadone level, or it can increase the QT interval. So there are many problems with the methadone. Other opioids doesn't have much serious interactions.
Thank you, sir. Any other last minute questions or points? Okay. In that case, I think we can wind up for the day, Sunil sir. Thank you for joining us. Personally, I am aware about your busy schedule and you could find out time for this cohort. In spite of that, thank you so much for that. And thank you each and every one of the participants for making this a very interactive session. I hope that most of you would have got at least one new piece of information from this session. So with that note, this is Sripriya along with Dr. Sunil Kumar signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care, bye-bye, and please don't forget to leave the feedback. Thank you.
Thank you. Thank you.